A very good morning to esteemed guests, distinguished faculty and delegates. It is indeed a pleasure to see the hall full for the inauguration ceremony, and it is indeed a privilege that Shri Rajesh Bhushanji, Secretary to the Government of India, Ministry of Health and Family Welfare, has consented to grace the occasion. So may I call the dignitaries on the dais. Shri Rajesh Bhushanji is here. Dr. P. Ashok Babu, Joint Secretary, Ministry of Health and Family Welfare. Dr. Rajendra Prasad, Deputy Director General TB, Division, Ministry of Health and Family Welfare. Dr. Zile Singh Meherwal, President IACTS. Dr. C.S. Hiremat, Secretary IACTS. Our guest of honor, Dr. Meenu Bajpai, Executive Director of National Board of Examinations. Dr. Rajan Santosham, President, Indian Society of Thoracic Surgeons. And Dr. Bhabatosh Biswas, the RC Jain orator for the day. We would now request Sister Girja to kindly welcome our chief guest with a green welcome.
I think we can move one step that side across. Yeah.
Sister Shima would now welcome Dr. Rajendra. Sister Gayatri. Would now present the green welcome to Dr. Meherwal. Mrs. Sakshi would now present a welcome to Dr. Meenu Bajpai, who is our guest of honor for the day. Ms. Girja would now present a welcome to Dr. Hiremat, Secretary IACTS. Ms. Shima would now present a welcome to Dr. Rajan Santosham, President ISTS. Ms. Shima would now present a welcome to Dr. Bhabatosh Biswas, our RC Jain orator for the day. Now I would request Sister Shima to kindly present a bouquet to our director, Sir Dr. Ravindra Kumar Diwan. I would now request our director, Sir Dr. Ravindra Kumar Diwan, to kindly welcome the gathering. Thank you.
Good afternoon, everybody. And it is my pleasant duty and privilege to be welcoming all of you to this thoracic CME, which is being held under the auspices of Indian Association of Cardiothoracic Surgeons. I have a great pleasure in inviting our chief guest, Shri Rajesh Bhushanji, the Honorable Secretary to the Government of India, Ministry of Health and Family Welfare. Shri Rajesh Bhushanji is a 1987 batch IS officer who has worked extensively in the fields of rural development, health, education, information. We are very pleased and honored to have you, sir, amongst you. Thank you so much, sir. I welcome to our institute the Deputy Director General TB, Shri Rajendra P. Joshi ji, and who is spearheading the entire program of Indian government to be in its ambitious target of ending TB by the year 2025. And he is a great friend. He has been a supportive of this institute on several occasions. Thank you so much, sir. I have great pleasure in inviting Dr. Minu Bajpayee, the Executive Director, National Board of Examination, to the institute. He also is our guest of honor today. He has kindly consented to attend this occasion. Thank you so much, sir. I have great pleasure in inviting my old friend as well as the very senior cardiac surgeon who is President of Indian Association of Cardiovascular Thoracic Surgeons, Dr. Jile Singh Meherwal. He was graciously asked us to conduct this thoracic CME and gave us this honor. Thank you so much, Dr. Meherwal. The Secretary of the Association, Dr. C.S. Hiremat, very dynamic Secretary of the Association. He has brought enormous changes to the Indian Association of Cardiovascular Thoracic Surgeons. I have great pleasure in inviting you here, sir. Thank you, sir. And of course, all of us know Dr. Rajan Santosham, who has been pioneer in developing a new society, Indian Society of Thoracic Surgeons, and his capacity as President of Indian Society of Thoracic Surgeons has kindly joined us. This institute was in hospital under TB Association of India till 1991, and in 1991 our then medical superintendent, Dr. R.C. Jain, and then he became the first director of the institute. He converted the institute into an autonomous institute under Ministry of Health and Family Welfare. In his memory, every year we commemorate it by awarding an oration lecture to any senior thoracic surgeon, pulmonologist, TB researcher, or epidemiologist. And this year, Dr. Bhabatosh Vishwas, a senior cardiac thoracic surgeon from Kolkata, has agreed to deliver this lecture. Thank you so much, sir. Now, a few words about Indian Association of Cardiovascular Thoracic Surgeons. It's a growing body. I remember the days in 1992 when we had only 250 to 300 members, and I was a young MCH cardiothoracic surgeon who joined it. Every year we used to look forward to its conference very eagerly. Now, as Dr. Hiremat tells me, it's a body constituting almost 2,500 members. Down the period, we realized that most of the focus of Cardiothoracic Surgery Association is on cardiac surgery. But there are a substantial number of cases in the country who require some kind of general thoracic surgical intervention, which may be ranging from complications of tuberculosis, lung cancer, trauma cases, and there are several other organs in thorax, like diaphragm, esophagus, etc., which also need attention, and trachea. So we thought that there should be a continuing medical education program on thoracic surgery separate from cardiac surgery. And that has been held continuously since 2004. And Dr. Hiremat actually has added a lot of new ideas into this program, has made it more interesting, enthusiastic, as well as more interactive. And about thoracic surgery, to fill up the gap of thoracic surgeons in the country, Dr. Rajan Santosham, Dr. Bhabatosh Vishwas, and several others of us have decided to form a separate Indian Society of Thoracic Surgery, as well as in this institute, with the guidance of Dr. Bhabatosh Vishwas and DNB, we started a separate standalone program of Diplomate in National Board in Thoracic Surgery since 2015, which has been running for last 7 years now. We already have produced 12 thoracic surgeons dedicated to the art and science of thoracic surgery. And in addition, this institute is also training general surgeons who are working in as faculty members in various state institutions for a 3-month fellowship in thoracic surgery. And this fellowship, sir, is also being supported by International Union Against Tuberculosis, and they are also supporting it financially in terms of giving a stipend of 1 lakh rupees to the fellows who join us here. And we are providing residential accommodation to them. So we are committed to the cause of thoracic surgery, its development, as well as the possibility that these facilities reach the masses in every nook and corner of the city. And I think I have to particularly thank the government of India, its senior officials who are Shri Rajesh Bhushanji represents the top apex of that hierarchy, bureaucratic hierarchy, which is supporting this institute in its development. I have been working as director for last 2 years, and my interaction with all the officials of the institute has been greatly supportive as well as encouraging. I'm extremely grateful to them. And I have to mention particularly that this year, they even have supported us by approving financially various new initiatives like robotic surgery, bronchial artery embolization, a skill lab in thoracic surgery, as well as They have given us an in-principle approval for a new master plan. As we know, most of the building of this institute is a little old and requires renovation. That has also been given, and we are extremely grateful to you, sir, for all your support, which is continuing ever since. Thank you so much. And we should also mention that this institute, especially after the COVID epidemic, has been receiving a lot of NGO and voluntary support. I think we were counting last week that up to a tune of rupees 15 crores worth of equipment we have received from various sources in the last 1 year itself. And we are grateful to all these people. So this shows the commitment of the society also. And when I mention society, we know under Shri Rajesh Bhushanji's stewardship, we recently launched the Nikshay Mitra program. So even the Nikshay Mitra program, in which community participation for elimination of TB is very important. And in this, we are finding various NGO partners, corporates, etc., which are helping our institute to develop as a center of excellence, as well as to support the TB elimination programs of Central TB Division. And my faculty, including the senior doctors like Dr. Puri, Dr. Sangeeta Sharma, etc., they have been constantly putting their inputs in refining, developing, and further drafting the program as it develops and becomes more sensitive to the needs of the patient. And with this, I welcome all the senior delegates who have come from various corners of the country, including Dr. Pooja, who has come from Washington, D.C., actually, and all the senior faculty from my institute who have joined. I hope the deliberations of the 2 days are meaningful and helpful to all of you. Thank you so much. Thanks.
Thank you, sir, for your continuous efforts in the development of the institute as well as thoracic surgery. May we now invite Dr. C.S. Hiremat to introduce the Indian Society of Thoracic Surgeons.
Good morning. Respected Sri Rajesh Bhushanji, Honorable Secretary, Government of India, Minister of Health and Family Welfare, dignitaries on the dais, Dr. R.P. Joshi, Deputy Director, President of IACTS, Dr. Zile Singh Merwal, past Presidents of IACTS, Dr. Rajan Santosham, Dr. Babitosh Bishwas, Executive Director of National Board of Examinations, Dr. Meenu Bajpayee, Organizing Chairman and Director of National Institute of Tuberculosis, Dr. Ravindra Kumar Diwan, Organizing Secretary of the IACTS Thoracic CME, Dr. Pallavi Purwar, Joint Secretary, Dr. Saranj Bansal, International Faculty, Senior Vice President of our association, Dr. Lokesh Sajja, Executive Committee members, dear friends and colleagues. It gives me immense pleasure to be here amongst you all. In fact, to brief about our association, which is about 69 years old today, stands forefront across the world. As Dr. Diwan put forth, in the last 4 to 5 years, we have taken a lead across the globe, whether it is academics and training of our junior colleagues. In fact, I would like to quote what the American President, Dr. Mark Moon, had made a comment during the COVID times when our masterclass series was introduced through IACTS across the world, where more than 26 countries participated in this masterclass series. In fact, Mark Moon made a comment before beginning his class in the masterclass series. Indian thoracic of cardiovascular surgeons have taken a lead in training and executing their techniques into the youngsters, where even Americans have failed to do so. This was a comment made by the American President, Dr. Mark Moon, which is on record even today. The association conducts about 4 CMEs and 1 national conferences every year. In fact, we have our national conference wherein we have adults, pediatrics, thoracic, minimal access, all specialties, subspecialties come together, and exclusively one hall is exclusive for thoracic surgery per se. That's usually conducted in the month of February. And the remaining, we have Techno-College CME, which we keep advances with the recent advances, what's happening in day-to-day practice, which is conducted in the month of May every year. And the midterm CME is conducted in the month of August, and thoracic CME either the month of November or December. Apart from this, Last 8 years, we have introduced another program for the students, what we call it as ISTS core program. It's exactly like a preliminary examinations for the students. Whoever attends it, the passing rate is almost 99% plus. And Dr. Minu Bajpayee was the chief guest of that program twice for that score program. Here I would like to put on record that National Institute of Tuberculosis, under the leadership of Dr. Ravindra Kumar Diwan, came forward to conduct this CME in our capital city of India. In fact, the amount of exposure what we happen to have a recent hospital visit in the morning now. The amount of work they do is quite appreciable, and in fact, only few of them do this kind of work in the country. We have the stalwarts of thoracic surgeons in India. In fact, who does exclusive thoracic surgeons? We have very few on our hand count. And that is where we are looking at, and they have started exclusively DNB thoracic training program in our country, where students are going into, and the first batch students also have come out. Not only this, I appreciate Dr. Diwan's initiative, wherein he has started training general surgeons, wherein 2-tier, 3-tier cities in rural areas where the thoracic surgeon is very much required, where there are general surgeons who always have that fear of handling the thoracic case. Even they are getting trained with 3 months fellowship program. I do really appreciate, sir. I would request the National Board of Examinations also to take such kind of curriculums for the youngsters, for general surgeons, wherein a certified course by the National Board makes a lot of difference in their regular practice. Not only this, the association is taking a lead in going on live workshops. In fact, cadaver workshops also have been conducted, whether it is the heart transplant, lung transplant training, which is happening in most of the conferences. Even lobectomies, pneumonectomies subsequently will be introduced in the cadaver hands-on training programs, which we are looking into in the upcoming conferences. All these things are done mainly to encourage the youngsters to join these courses. Of course, there is a lacune of late. The amount of intake for the CTVS per se, whether it is thoracic surgery or cardiac surgery, the interest among the students has come down. Well, that may be because we seniors are at fault, or the training per se is at fault, which we are looking into. And today, after this meeting, we have a detailed discussion, revision of our curriculum with the National Board of Examiners of Directors, our Minu Bajpayee and Abhijat Seth also. So after this, we happen to do a homework across the country, wherein all the surgeons put forth their thoughts, what best can be done to nurture this field, which I definitely will come into things. If you ask me, even in United States of America, recently happened to meet one of the surgeons, wherein he told even the USA that takedown of seats in CTVS was less, but of late when they did their homework and when they looked into today, last 2 to 3 years, the amount of intake has gradually very much increased. That's mainly what they found out was the job opportunities for these students were less, and the government played an important vital role in that, wherein a lot of job opportunities were created for these thoracic surgeons. And today in America, USA and UK, the seats are not going vacant. This is the recent information in the last conference which I got, which is very much important. And today we have the ministers here, National Board executive directors here, which we can put forth. And finally, when we change the curriculum and the way we look at the job opportunities for these surgeons, definitely we can make a huge difference. And not only this, I would like to congratulate Dr. Ravindra Kumar Diwan and Pallavi Purwar and her team for coming out with an excellent scientific program. It's a scientific feast of 2 days covering tuberculosis, which is the largest in the world. Our country is facing a challenge, and even on lung cancers, infections of the chest trauma, all these matters are covered in these 2 days. I request all the students to participate, and not only that, she has taken an additional plan of conducting a quiz, which is first time in the thoracic CME. A quiz has been conducted for the benefit of students with a very good attractive prize. I request all of them to participate and utilize these 2 days and see that it's quite fruitful and helpful for all of them. Thank you once again.
Thank you, sir, for your kind words. May we now request Dr. Rajendra P. Joshi, sir, DDG TB, to kindly share his insights.
Namaste, good morning all. Respected Rajesh Bhushan Secretary Sir, and all the dignitaries on the dais and off the dais. I'm very thankful to the organizers for giving me this opportunity of participating in a very, very important part of medical field. But somehow it has been like a very good fruit behind, covered by the leaves. It is not getting the amount of exposure or awareness even among the medical fraternity. So I congratulate the organizers for organizing this CME and taking it especially for the students who are the future of our country. I was looking at the data and I was surprised that the first surgery, thoracic surgery, was conducted about 300 years ago, 1726, for tuberculosis. But even today, as a tuberculosis program manager, I feel that the awareness of the role of surgery, whether it is for diagnosis or treatment or even rehabilitation, is somehow there is a need for our team, say a district level TB officer or a taluka level TB officer, to know what is the role of surgery, where it can be done, which is going to help the patient, so that he can refer to appropriate center. So on request Dr. Diwan sir, who has been very supportive of the tuberculosis program, to kindly help us in developing an IEC material so that I can distribute across my team. See, there are many advancements, and thoracic surgery has seen immense advancements in recent years. But somehow, once our doctors start practicing in a peripheral unit, they may not be aware of all the happenings. So this material will definitely help, and I think there is a very good need for creating awareness through all our other medical organizations, say Indian Medical Association and other organizations, so that what is happening in thoracic field surgery should be communicated. My next request, especially for the students, is to do research in tuberculosis from thoracic point in India. What we require is research in India, publications from India, so that we can develop guidelines which are specific to our country, our region, instead of following the outside one. So I think there is a lot of scope for doing research. We have got a huge number of patients. We have got a huge number of experts like you. So what we require is documentation and publication. So once again, I thank the organizers for giving me this opportunity, and I wish the CME all the best. Thank you.
Thank you so much, sir, for your encouraging words. May we now request Dr. Z.S. Meherwal, President IACTS, to share his insights.
Shri Rajesh Bhushan, Secretary Health, Ministry of Health and Family Welfare, Dr. Joshi, Deputy Director General, Tuberculosis Division, Ministry of Health and Family Welfare, Dr. Menu Bajpayee, Executive Director of National Board of Examinations, my friend Dr. Rajan Santosham, a very senior thoracic surgeon, Dr. Bavados Viswas, again a very senior thoracic surgeon, my friend Dr. Hiremat, Secretary of the IACTS, and Dr. Ravinder Diwan, the Director of the Institute. Friends, a very good morning to you. In fact, a very good afternoon to you all. Let me first thank the officials from the Ministry and the National Board of Examinations for coming and gracing this occasion, because I think the two things which are very important in any field, including our medical field, a good collaboration between the ministry and the institute or the body which makes the curriculum and looks after the teaching and training of a particular specialty. So National Board of Examination obviously is very important, and the Ministry of Health is important. All of us know that cardiovascular thoracic surgery has evolved over the last 7 decades, and today, now we have sub-specialties in this so-called super specialty. So we have adult cardiac surgery, we have pediatric cardiac surgery, we have thoracic surgery, and in the adult cardiac surgery we have multiple sub-specialties. So it has certainly evolved at this stage into the areas which certainly were common before. Most of the surgeons, the senior surgeons today, they actually have practiced or they have been trained as thoracic surgeons. All of us sitting here, they have been trained as thoracic surgeon. But for some reason, thoracic surgery has not remained the favorite subspecialty of many cardiovascular thoracic surgeons. At the same time, we know there is a huge demand, a huge need of thoracic surgeons in our country, particularly because we have so many patients who have sequelae of chronic infections, including tuberculosis, which unfortunately continues to be very common even today in our country. At the same time, the thoracic surgery has certainly grown, evolved, and there are a lot of developments in the last couple of decades, including the video-assisted thoracic surgery, the robotic thoracic surgery, and lately, the lung transplant. So there are many thoracic surgeons who have dedicated themselves to the video-assisted surgeries or to robotic surgeries, and many young surgeons now are taking up the lung transplant as their area of interest. So there is a lot of scope. It is up to us how we make it attractive for the young generation. The cardiovascular thoracic surgery in general, unfortunately, for the last, I would say, 10-15 years, has not remained a very favorite subspecialty of doctors coming after their graduation or post-graduation, and we certainly have to look into this collectively. So as we evolve, we have to see how we can make it more attractive for our young generation, how we can train our young generation so that not only they can give the best to their patients, but also can have a professional satisfaction and can establish themselves as a good cardiac surgeon or a good thoracic surgeon or a good vascular surgeon. The Indian Association of Cardiovascular Thoracic Surgery has been working very hard over the years in spending a lot of time, lot of efforts and energy in teaching and training of not only the students but also the young surgeons, with the objective that we can help our students to pass their exam and at the same time help our young surgeons to upgrade and uplift their skills in particular area so that they can establish in a particular subspecialty. For example, the heart transplant today has become one of the areas where a lot of people are taking interest. Minimally invasive cardiac surgery has become an area where people are taking a lot of interest. So as our specialty grows, we have to continue to look at what we can do as the association, as the senior surgeons, the senior faculty members, to make it more interesting for our young generation. And with that, in fact, the ICT has started many fellowships a few years back. So currently we have fellowship in the congenital cardiac surgery, we have fellowship in the, recently we have started the fellowship in the vets also. We have fellowship in coronary surgery as well. And the idea is that we should be able to train our young generation in a particular area so that they can establish themselves in that field. So I think we all have to work hard to make sure that we gain the interest of our young generation. The thoracic surgery, as I mentioned, certainly needs a lot of attention. The DNB students, they have to rotate in thoracic surgery for a few months. In fact, we have been sending our students to this institute for the last many years, and I can tell you, they certainly get an exposure which certainly generates some interest in thoracic surgery in those students. Of course, it's a short period, 6 months or 4 months. It's certainly not a long period, but I must say, in fact, I need to thank Dr. Ravinder Diwan and Pallavi for helping our DNB students in training of thoracic surgery in this institute. I strongly believe that the thoracic surgery certainly deserves more attention, not only from us as the society, but also to make sure that our patients, which are in huge numbers in the country, get the best care. I congratulate the organizing team, Dr. Ravinder Diwan, Dr. Pallavi, and the rest of the team to organize a wonderful CME, putting up an excellent scientific program, which I'm sure is going to be useful for all the participants because it covers all the areas of thoracic surgery. And I'm sure at the end of the 2 days, everyone will certainly become wiser in this field. On behalf of the Indian Association of Cardiovascular Thoracic Surgeons, I thank the people from the ministry and the National Board of Examinations for gracing this occasion, and wish you all good 2 days and a good CME. Thank you much.
Thank you so much, sir, for your kind words. It is indeed our privilege to now invite our guest of honor, Dr. Meenu Bajpai, sir, Executive Director, NBE, to share his thoughts and insights.
Most respected Shri Rajesh Bhushan ji, Secretary Health, Ministry of Health and Family Welfare, Dr. Rajan Santosham, Dr. Hiremat, Dr. Joshi, Dr. Bhabatosh Vishwas, Dr. Diwan, dignitaries in the audience, students and friends. It's a privilege to be here during the 69th meeting of the association of known as IACTS. And in this hospital, which is an old hospital which has trained so many people and which has done phenomenal work as far as the thoracic surgery is concerned. I can see many consultants here from whom I get referral of cases in the institute when there are problems to be discussed on both sides. Now, National Board of Examination is entrusted with training of postgraduate students. And just to brief you that we currently have 13,000 postgraduate seats every year. We have about 1,300 hospitals in the country where we have accredited centers for training. 2/3 of these are private hospitals. And recently, we have taken a census and we have found that our numbers of PG seats has increased under the support of the ministry and Shri Rajesh Bhushan ji from 415 in 2016 to currently the number, as I said, reaching out to 13,000 seats, which is a more than 200% increase. For any good work, we need all 360-degree support, and I would only say that administrative support has been monumental in whatever we are trying to achieve. I bring to you today also greetings from our President, Dr. Abhijat Sheth, who is himself is a cardiothoracic surgeon, and he's a British citizen, but he chose to support and help India in the progress of postgraduate education, and he has been for the last 7 years as its president. So, now, as I said that the specialties which are under the ambit of the National Board are 100 specialty boards, which includes broad specialties, super specialties, fellowship programs, and diploma programs also. And I, as briefly chipped by the Health Secretary Sahab, he said that the outreach to our district hospital in ramping our specialist has been a very important effort which national boards have contributed, where we offered diploma courses also. And somebody was mentioning that you are allowing 3 months rotation of general surgeons to be exposed to thoracic surgery. I think this is a wonderful thing. Our country needs a fair exposure of thoracic surgery. Unfortunately, CTVS, as the name denotes, are lot of cardiothoracic surgeons, but their main training has been in cardiac surgery because the kind of training they received in cardiac surgery of all way cannot be done by anybody else. Whereas people feel that thoracic part of the surgery can be done by general surgeons also, which has been done also over the period of time. But we are in times now where there is organ-based surgery. So we should have a separate cadre of people who are thoracic surgeons trained into this so that they can deliver much more. Now, in brief, our country has seen and witnessing currently 2 major explosions, just like anywhere else, but more so in our country. The technological advances which are being made in the specialties, and secondly, the massive infrastructure expansion which has taken place in our country in the last few years. I'll go to those statistics in a little while. As far as the technological advances are concerned, major surgical interventions, maximally invasive surgery has given way to minimally invasive surgery, largely because now we have better optics, we have got more miniaturized instruments, and patients, when they find that there is a minimally invasive surgery option, they would not go in for a maximally invasive surgery. I mean, this is something which is very, very consumer related, and we should think ourselves as a patient, why would we go in for a major intervention when we can get it done by a simple buttonhole or a catheter? Now, there are concerns. Our country is a conglomerate. It's a different world. There are many worlds within our country, and we have to address that we are able to reach out to each aspect, the training and the trainee and the consumer market also. Now, I'll take 2 or 3 examples. I'll take the example to begin with of my specialty of pediatric surgery. Now, we used to do urinary bladder augmentation, making a long incision, taking a part of stomach and its gastroepiploic artery, thinking it down into the bladder part to augment it. Now we are doing it by 2 or 3 ports. The major incision is off. So obviously, if you can deliver that way, things would change. Another thing is POEM, the per oral approach to Heller's myotomy. Earlier it was being done by an open surgery followed by fundoplication. People moved to laparoscopy. Now we are doing simple incision on the upper esophagus, going endoscopically and doing a myotomy. Why would not a patient prefer that? And it has led to a kind of a turf war, if not a war, a gray zone, where endoscopic physicians can also do the same thing. They are encroaching on the turf. Therefore, we should pep up ourselves also. That trained surgeons also should train to those techniques more and more. I'll come to that, what National Board is doing for that and what your association is doing for that. CTVS. Open surgeries now, valve replacements are being done by simple catheterization. Even NASA has developed navigated systems. At the tip of a catheter, there is a camera and there is an X-ray device where you can see what is happening inside. So I think we have to also modify ourselves and adapt ourselves to the changing times. And so with these words, what National Board has done is what I'm going to tell. One more example. Renal artery stenosis used to be done by open surgery and grafts used to be placed. Many years ago, when this angioplasty for the renal artery stenosis came up, suddenly the number of cases of requiring this plasty rose in one major hospital from 300 per year to 1200. Where were these patients earlier? The patients were hesitant to undergo surgery. But with the angioplasty being a simple technique, suddenly that iceberg below the tip started coming up. So we are in changing times and we have to modify the curriculum, as Dr. Hiremet very pointedly mentioned, and that I received letters from many of your specialists that we should do something about it, and we have been doing about it for many specialties. So I'll tell you what we are doing. So to address these issues, skill labs are being introduced, training of trainers, and workshop for the assessors. Now, this is the larger framework, but coming to the skill training, with the encouragement of the Government of India, their concurrence and permission, and the finances that the National Board had, we are now developing a national skills center right at the heart of Delhi at the NBCC building that you see in the West Kidwai Nagar. This is a 45,000 square feet area where we would have an investment of almost more than 100 CR, and we will have state-of-the-art simulation for all specialties. And we'll begin with training of trainers, and it will also address many of the issues of specialties, including the wire technology, which Dr. Hiremet wrote to me. So many people who are training within their premises, they would be the national trainers, and they would be contributing to the whole sea of trainees across the country. Now, there are many other aspects also that we are addressing. I just mentioned to Secretary Saab, he knows about these things, but just to tell many of you that in our country, we need more specialists. And there are 10 most common causes of death in India cannot be treated by MBBS doctors alone. We have a shortage of specialists. Now, in order to improve that, we have introduced the program of joint accreditation. I'll take the example which is immediately under our nose. In the morning, I was talking to a thoracic, Dr. Pallavi, and she said, I am the alone thoracic surgeon in a unit of cardiothoracic surgeons, and she doesn't get much as far as the thoracic part is concerned. And she is not having a program of training people in thoracic surgery because she is alone. So as far as the accreditation criteria is concerned, she is not eligible. But if we put 2 hospitals, where each has got a thoracic surgeon, we will allow that to run a program of DNB, and that is going to be a long way. Lot of hospitals standalone have plenty of material because they are not able to have eligibility criteria. This joint accreditation will suddenly unmask the potential of hospital space, which can start training people, number of beds, eligible teachers, case mix will be huge. So this is something which we have already passed recently on the 25th of November governing body of the National Board. Very soon all of you will hear, and I'm sure we will suddenly have a spot of activity there. Briefly, we are introducing program of training of trainers, a center for faculty development, workshop for assessors, as I mentioned earlier, and including workshop of effective communication and soft and non-technical skills. This is very important. We often hear in the newspaper that there are angry exchanges between the patients, relatives, and the doctors, and a lot of things happen which should not have happened. So we want to introduce that aspect. The empathy proficiency, leadership, teamwork, critical thinking, situational awareness, or emotional intelligence. So all these are going to be foundation courses for every postgraduate who joins the program of National Board, and these soft skills will be introduced. So just a bird's eye view of what all is in the pipeline, and we have already begun the exercises. Now, what we also see is that in our country, there are many centers that they're not having uniform training patterns. Now, we have got a IT hub at Dwarka, which is the headquarters of National Board. We have enhanced the lines of transmission for webinars. We have doubled up the lines, and we have cleared the file for in our GB that will have 4 or 5 lines. So round the clock, the curriculum of specialties will be transmitted by all the stalwarts throughout the country. So somebody doing DNB or DRNB in cardiothoracic surgery, whether he is doing in Coimbatore or he is doing in Kanpur, doesn't really matter. The curriculum would be common, SOPs will be common, standard treatment workflows will be common. So the uniformity of training will be implemented. It is already being done. Many of you might be aware of that. So we are planning to have focus is on training of residents, online repositories so that it is accessible, online library. All this has been cleared, and it's a matter of time now an important thing which is missing out, and people often voice is that the academic environment in the private hospital is not good as the medical colleges. This is an old thought process. There are many medical colleges in our country where there is a very heterogeneous environment of training. If you look at some colleges, they are very good. There are extreme colleges also. Same thing is true in the National Board. But National Board has improved. I have been a trainer in the institutions, and I have been examiner to the National Board students, sir, and I have seen, because of the unique feature of National Board being a central university kind of thing, which transmits its curriculum and also monitors courses across the country. This central sort of transmission of courses has led to uniformity, and the NBE students have improved, quality has improved a lot. Most of you would testify this, whereas the MD, MS, MCH has not improved to that lot. It is because of the central nature of the National Board programs. Anyway, so what we are doing now to enhance the course, we are now taking the curriculum for better monitoring. So we are designing an app which every resident on his smartphone would have it. This app would have the curriculum of specialties right on the laptop. So whenever he is taking around and finishes either the OT or the clinic or the OPD or wherever he is, he would be able to clock how many cases he have seen, what has he learned from each cases. This formative assessment has got, in brief, 6 domains: patient care, medical knowledge, professionalism, interpersonal and communication skills, practice-based learning and improvement, and system-based practice. These 6 domains would be assessed through 3 milestones: skills, knowledge, and behavior. And each milestone would have a performance level, and which is in the form of a novice, advanced beginner, competent individual, proficient individual, and expert physician. So resident within 3 years of their training go through a ladder. They are initially novice, but gradually they should reach the full performance level. They should know every day, rather than the end of 3 years, they should know every day what have they learned today so that they can improve. This is formative assessment. So we are introducing it through the app. It's an expensive app, but we have got the mandate to do it through the protocol. Now, finally, just to give you a bird's eye view what the government is doing. Now we must know, and some Dr. Goel in the morning mentioned about the changing sort of sensitivities and the dimensions of the market. Obviously, people who are trained, they want a job also. So what is happening to the state of deployability and employability? So government is making enormous efforts in augmenting the healthcare infrastructure in the country. If you take into consideration the growing Indian hospital market, which stood at 66.77 billion in financial year 2021 and expected to grow to 120 billion in the next 2 years. This is the input in addition to what government is doing. And as a result of this, you can imagine what is the kind of market which is required, the kind of expectation in the postgraduate training programs it has put in. Joint accreditation is one step towards that, which is going to take into account. The government now has increased MBBS seats to 91,000, almost 92,000 in 600 medical colleges, 322 government colleges with 48,000 seats, and 290 private institutes with 43,000 seats, which is an increase by 8,652. Now, as far as the employability and deployability is concerned, Shri Rajesh Bhushan ji, our health secretary, has mapped, in fact, that day he was telling, he has projected the requirements. And in that requirement, taking into consideration about 152,000 sub-centers in the country, 20,000 PHCs, 5,600 community health centers, 1,200 sub-divisional hospitals, 756 district hospitals, all of them have been projected to have specialty positions. So, in short, I would say there has been a 360-degree effort, both by our training institution as well as the government of India, to ramp up the specialty requirement. We are constantly innovating curriculum modification. I keep my ear right at the ground level to see what is required. And as Dr. Hiram had mentioned, this is my third meeting of ICTS, because the idea is I must know what is happening, and I do it as much as I can. So thank you. With these words, I would like to thank the organizing committee. Also reassure about the efforts which National Board is making to address the PG training. Thank you so much.
Thank you, sir, for your vision for the future in development and training. Dr. R.C. Jain, an eminent thoracic surgeon, is the director founder of our institute. By his painstaking efforts in 1991, we became the autonomous body under the Ministry of Health and Family Welfare. And it was he was instrumental in development of thoracic surgery as well as development of the institute. So we have a tradition of awarding R.C. Jain Oration Award to eminent thoracic surgeons, clinicians or physicians who have given incontributable contribution towards development of thoracic surgery and TB. For this year, may I request Dr. Rajan Santosham, sir, President ISTS, to kindly read the citation for the oration.
Good morning, everybody. I had the privilege of meeting Dr. R.C. Jain, and I was the first orator of the Dr. R.C. Jain orator before the COVID. I'm so happy this has been continued. I'm extremely happy that my close friend and secretary ISTS and treasurer ISTS and past president of IACTS, Dr. Babatosh Biswas, nobody can miss him. There he is. He's been named as the orator. The National Institute of Tuberculosis and Respiratory Diseases, be it known to all to whom these present that Dr. Babatosh Biswas has been named as the Dr. R.C. Jain Orator of the year 2022. In deep appreciation of his distinguished work and achievements in the field of thoracic surgery, at this 17th day of December 2022, signed Dr. Ravindra Kumar Diwan, Director, NITRDC. I would request the Secretary of Health to hand over the oration plaque to Babatosh Biswas.
Secretary. We would now request our chief guest of the day, Shri Rajesh Bhushan ji, to kindly deliver the inaugural address.
Dr. Ravindra Kumar Jain, Dr. Ravindra Kumar and Dr. Hiremat, Dr. Meherwal, Dr. Santosham, Dr. Bhavtosh Biswas, Dr. Binu Talwar, Dr. Joshi, ladies and gentlemen. It's indeed a pleasure to be here on this occasion. The Institute has a fairly long history and a rich history from 1991 till date. And what is important is that it is not only providing exemplary service in the field of patient care, it's also doing significant work in teaching learning, in collaborative research, and in taking the entire area of TB treatment, TB diagnostics, surgery in patients who have complications because of TB to greater horizons. So that is the context in which this particular CME should be seen, because otherwise you would have seen that all disciplines, all specialities, all super specialities do have regular CMEs. But why is this CME or this kind of CME becomes important? It becomes important because we live in a country which has the highest burden of tuberculosis, and we have committed ourselves to eliminate this disease by 2025, which is 5 years in advance to the Sustainable Development Goals target of 2030. So if that is the case, what is required? In very simple terms, what is required is to identify your universe. Until and unless we identify all TB patients, how would we then bring them under treatment, and the smaller proportion of that universe that requires surgical intervention should have access to surgical intervention. So therefore, identification of the universe, therefore better and as far as possible point of care diagnostic techniques, therefore once the diagnostic techniques have been administered and results are known, quick initiation of treatment, and also completion of that treatment, and also access, prompt access for surgical intervention in respect of patients who require that surgical intervention. So all these things are related. However, there are major challenges. What are these challenges? We are a huge country. We are in fact many countries rolled into one, a country of almost 137 crore people, and with diverse landscape from hills to forest lands to islands. So this program has to be run across all these states. And if you look at the availability of medical officers, you would find that while in the metropolitan cities, maybe also tier 2, tier 3 towns, you may have some specialists, but as you go down at the district or sub-district level, what you have are more in the nature of general duty medical officers. So therefore, we in the ministry have 3 very specific ideas, which I keep on discussing with Dr. Diwan, with Dr. Joshi, and with almost anyone who, I am able to grab. So the first idea is to repurpose our general duty medical officers. They must be repurposed, and it can be done, and it will not be an encroachment into anyone's domain. Repurposing of roles is absolutely important, and we realized during the last 2.5 years of COVID management that we were able to do it because we did this for GDMOs by training them in critical care medicine. No one had ever thought that we would be in a position to do it, say 3 years ago. But this happened because we required these people. There were critical cases of COVID who were coming to district hospitals. We couldn't have said कि हमारे पास नहीं है critical care medicine का कोई आदमी. We cannot, provide you the standard of care. So therefore, the people who were available were repurposed. So that brings me to the first point that I was saying. We need to repurpose our GDMO kind of medical officers who are available in large number in our districts and sub-district levels into recognizing the symptoms of TB, knowing which are the diagnostic techniques available, what are the symptoms of drug-resistant TB, which are the candidates for a surgical intervention. So this is a exercise which has to be done on a large scale across the country. It's good to know that under Dr. Diwan's initiative, we have started this, although it then got stuck because of the COVID, but we need to restart this. The second point is that at the district and sub-district level, we do also have general surgeons. Their exposure to cardiothoracic surgery techniques and such procedures is important. And please appreciate the fact that I am saying exposure. So their exposure must be done. And we need to create some physical, some digital, some phygital training modules in this. And that is where NBMS and specialized institute like Dr. Diwan's and others can collaboratively play a role. The third important thing that we need to do is to ensure that whenever we have, now I am coming to the super speciality aspect of it, whenever we have such CMEs, our students in large number must be part of such interactions, because eventually this universe of available super speciality people must increase. I was discussing with Dr. Hiremat, and he said that roughly around 3,000 plus such professionals are available. The idea is, how do we exponentially scale up this number? 3,000 in any other country would have been a significant number. लेकिन हमारा देश 137 करोड़ की आबादी, उसमें हम कह रहे हैं कि 3,000 लोग हैं जो कि इस सुपर स्पेशलिटी का ज्ञान रखते हैं. So there is the main challenge. Our numbers are huge. When we talk of malaria, huge numbers. Talk of TB, huge numbers. So therefore our requirements are equally great. Therefore the need to quickly look at increasing our MS, MD, DNB seats is equally great. And this is where the new initiative that government fully supports and is being rolled out by NBMS comes into play, which is that if you have a hospital and you have another hospital, both tertiary care facilities, they are willing to join hand and they draw up a simple, say, 2-page agreement that we would jointly apply for accreditation to run a DNB program in cardiothoracic surgery, then so be it. This is happening for the first time. And this is a great innovation. When you talk to your peers, your colleagues, you must tell them that private hospitals or private or government hospital, they must come together to utilize this opportunity. So these were the three specific points that I thought that I would underline while interacting with you. I wish this CME well, and I hope that all of you at the end of this 2-day intense deliberation go back enriched and fully satisfied, and I hope that going ahead we would be able to achieve our targets in the field of TB elimination. Thank you once again.
Thank you very much, sir. Your leadership and vision is an inspiration for us all. May we now request our director, sir, to kindly felicitate our chief guest, Shri Rajesh Bhushan ji.
And I was the past president and secretary of You'll have a group photo. Yes, yeah, come.
With this, we conclude the inauguration ceremony. We would like to thank all the dignitaries for gracing the occasion. All the thoughts and insights and wisdom is definitely going to help us. We would like to thank Indian Association of Cardiothoracic Surgery for giving us this opportunity. We would like to thank Team NITRD for their continuous efforts. Thank you. We'll break for lunch and